Every gastroenterologist has had a difficult consult. Almost every day they go to work, frankly. So I'm Brennan Spiegel. I'm Director of Health Services Research for Cedars-Sinai Medical Center. Functional GI disorders in particular account for maybe 1/3 of the general GI practice, and can be very, very challenging cases. So it's very common to have difficult situations where the doctor is really unsure exactly what is causing the symptoms, how best to manage the symptoms, and really that's the focus of what we call the difficult GI consult. It's very, very common. Sometimes we see patients who have abdominal pain and we really can't quite figure out the cause of the pain. And the traditional approach is to sort of test all sorts of things. But if we can't take a photograph of the problem, run a blood test for the problem, do an x-ray for the problem, and can't find the problem, we end up sort of stuck in this no man's land. And that's where we usually call it the difficult consult. But really, it's important to think about not the biomedical model, but the biopsychosocial model. This was a model that was described by George Engel in 1977 in the journal Science. And at that time, he said, we have a problem in modern medicine. The problem is that people have been trained in this mechanistic way of thinking, that the mind is in one place and the body is in another, and the two should not be related. This Cartesian mindset of mind and body. But since that time, we've come to realize that the brain is yoked to the rest of the body. It has governance over the body. It is linked to the body neurologically, endocrinologically, immunologically, and physically. It is part of who we are. So the difficult consult often comes down to understanding and appreciating that. And sometimes it's just about talking with patients, understanding their biopsychosocial illness experience, not just disease, but illness experience. And George Engel coined that term, the illness experience. It's a broader concept that health is not just about physical well-being, but also about social well-being and emotional well-being. And as gastroenterologists, we can help across all three aspects of biopsychosocial health. Many gastroenterologists we're not really expecting to be psychologists, we're expecting to be surgeons. And yet when we find ourselves in everyday practice, in a way we're sort of playing psychologist for many of our patients. So it is vital that gastroenterologists accept that, feel comfortable with biopsychosocial medicine, and develop skills. The sorts of skills that Doug Drossman has been teaching for years and others, to become comfortable in engaging patients in the tripartite model of health, biopsychosocial health. That's not to exclude our biomedical training. It's not mutually exclusive with being able to take a food impaction out or to stop a bleeding vessel or to cure colitis. But it is part of what we do in gastroenterology. To some degree, we also cure just by being there and just by listening. And that's something that can be taught. Realizing that therapies like virtual reality, which has no active drug ingredient, may be able to replace opioids, can help with abdominal pain. Understanding the role of mindful meditation and of yoga and of cognitive behavioral therapy. All of these things have an important role in modern gastroenterology, right alongside all of the biologic therapies and motility therapies and everything else that we have that also work really well. Put them together, and we're so much more powerful as healers than we are if we just look at one or the other unto itself.